Patients with colorectal cancer, when the aim is to cure, will most of the time require a resection of the bowel, and most often with a reanastomosis, meaning a connection of the bowel. Fortunately, many patients will heal well, but up to 20 to 30% may have a healing problem, and this gives infection. It's called an anastomotic leak. Having an anastomotic leak increases morbidity, mortality, and probably cancer recurrence. So there is major impact. Some patients have predictable factors for this infection. However, certain patients do not have any predictive factors.
After surgery, tissue repairs begins immediately, involving the production of fibronectin and fibrin matrix to temporarily seal and connect the two bowel ends. This is followed by inflammatory phase and a remodeling stage, during which the new epithelium and the final scar tissue are formed. The process of bowel repair after surgery may be affected by gut microbiota, the collection of microbes, mainly bacteria, that inhabit the gastrointestinal tract. Gut microbiota might directly modulate the different phases of wound repair and hence influence the healing process. In these studies, we investigated the causative role of gut microbiota in the pathogenesis of anastomotic leak in patients with colorectal cancer.
Our first experiment consisted of collection before surgery of fecal samples from patients with colorectal cancer who had or not anastomotic leak, followed by fecal microbiota transplantation using these samples into mice that were then subjected to colonic surgery. Mice receiving the microbiota of patients with anastomotic leak had a higher rate of anastomotic leak after surgery and a weaker gut barrier function after the operation.
Using a high-resolution microbiome profiling pipeline called Anchor, we were able to identify 24 bacterial species and 4 genera that were differentially abundant between the groups. To narrow down this list to bacteria most important to healing, we developed a machine learning algorithm that identified 12 microbiota features most predictive to anastomotic leak. More importantly, the prediction was equally high between the mice and the patients. Among those features, a strain of Pyrobacteroides goldsteini was found to be positively correlated with healing parameters, while a strain of Alistipis orthodonti was found to be negatively correlated with anastomotic healing.
To assess the biological role of these bacterial strains in mice, we supplemented mice for 2 days with Pyrobacteroides goldsteini or Alistipis orthodonti and then operated on them. We found that supplementation with Alistipis orthodonti increased the rate of anastomotic leak in mice and weakened the gut barrier function, as shown by higher bacterial translocation to the spleen. On the other hand, P. goldsteini was shown to be beneficial, decreased the rate of anastomotic leak, and strengthened the gut barrier function after surgery. Mechanistically, P. goldsteini was shown to be anti-inflammatory and to inhibit the tnf-κB pathway in the gut, while Alistipis orthodonti had the opposite effect and was shown to be pro-inflammatory in the gut. Knowing that the anti-inflammatory P. goldsteini was less abundant and that the pro-inflammatory Alistipis orthodonti was more abundant in patients with anastomotic leak, we next questioned whether these patients have higher levels of low-grade inflammation in the gut even before surgery. And we found indeed that mucosal tissue from patients with anastomotic leak collected during surgery, even before the anastomosis has been constructed, harbor higher levels of pro-inflammatory cytokines. And interestingly, this higher level of pro-inflammatory cytokines was transferable to mice by fecal microbiota transplantation, confirming that this phenotype is microbiota-driven. Using a review of all cases of anastomotic leak in our institution over the last 10 years, we found that patients with anastomotic leak had higher levels of circulating neutrophils and monocytes before surgery. We then questioned whether decreasing these circulating levels of neutrophils and monocytes could improve anastomotic healing in mice. So we used clodronate liposomes and monoclonal antibodies to decrease monocytes and neutrophils respectively. and we found that indeed decreasing circulating levels of these blood cells improves anastomotic healing in mice and reinforces the gut barrier function. To conclude, bacterial strains, including P. goldsteini and A. underdonkey, regulate the levels of proinflammatory cytokines in the gut and influence the repair of anastomotic wounds and the restoration of the gut barrier function after surgery. Most importantly, we show that patients who develop anastomotic leak harbor higher basal levels of low-grade inflammation in the gut, which influences their outcomes after surgery.
Patients at risk of developing anastomotic leak could be candidates for treatments before surgery targeting gut microbiota. Treatments such as prebiotics, probiotics, and postbiotics could attenuate colonic inflammation, strengthen the gut barrier, and improve anastomotic healing. In addition, microbiota-based approaches could be relevant for other oncological and non-oncological situations in which gastrointestinal interventions are required.
We explored in this paper potential screening markers related to low-grade gut inflammation in anastomotic leaks. Lipocaine-2 and calprotectin were identified as potential screening low-grade inflammation markers prior to surgery. Identification of low-grade inflammation prior to surgery to identify patient at risk of poor outcome paves the way to personalized medicine for treating colorectal cancer patients.